Hello everyone, and welcome to another audio podcast around another important kidney related disease subject, and this is work that's a basis around hematology, immunology, and also a little bit around transfusion. This topic is around a disease, a particular kidney disease related pathology that focuses on what is known as Henoch-Schonlein Purpura, or HSP, and this work looks at the biomedical and clinical anatomy practice on this multidisciplinary disease. This work was published. Has been published in a peer-reviewed publication in a anatomy-based peer-reviewed journal in 2018, and this work is an overview that has been accepted for poster presentation at the International Pediatric Nephrology Association conference for this year 2022. And I thought I'd take this opportunity as one of the lead authors of this work to provide an overview on this particular subject. Again, this work is available through the Renal Patient Support Group, or the RPSG, so I'm going to provide this overview. Initially providing a bit around an intro to this particular disease. So Henoch-Schonlein Purpura is what is known as characterized by a triad, or three main symptoms. So it's number one is palpable purpura without thrombocytopenia. So purpura is in layman's terms, it is what is known as bruising, but without a high, in some contexts, without a high platelet count or thrombocytopenia. Number two is abdominal pain, and number three is arthritis. So renal involvement or kidney involvement often can occur in children or adolescents, and it is more frequently seen in males versus females. And in spite of its being a self-limited condition, Henoch-Schonlein Purpura can cause renal manifestations with various indices. The guidelines and treatment for managing care in such patients ranges between centers. Long-term prognosis depends really actually on the severity of renal involvement or kidney involvement, which may manifest as persistent haematuria. Haematuria is where individuals could be avoiding urine avoiding urine normally, but actually also bleeding out. So parts of when they do micturate or have a sensation to void urine, they actually, when they do eventually void, they unfortunately void blood through their urine. And there's also proteinuria, where patients can avoid protein. And then there's also nephritic and nephrotic syndrome, or even ultimately renal failure. And to prevent or delay end-stage renal disease, or ESRD, identification of early stage nephritis or scarring the kidneys is important. The risk factors associated with renal involvement in Henoch-Schönlein Purpura are not clear, although epidemiological and clinical features, as well as some abnormal laboratory findings, have been suggested to have a predictive role. So a little bit around the epidemiology around this particular disease, particular disease. So HSP, or Henoch-Schönlein Purpura, is one of the most common vasculitis conditions in children, occurring in 8 to 20.4 per 100,000 children per year. HSP usually occurs in children aged between 2 to 10 years. That being said, there are children or young people who can be in early to late adolescence, who can be diagnosed, and then in part of where they are diagnosed, once they're diagnosed, and particularly in late adolescence, will then have, for example, if they're in late adolescence, and there is a definition around this in literature where patients are diagnosed in late adolescence. It's actually at the time where they may transition from pediatric renal kidney services into adult kidney services, and so HSP, Henoch-Schönlein Purpura, usually occurs in children or young people between 2 to 10 years of age, and with about 50% of all cases occurring in children aged less than 6 years of age, but mostly in children age 4 to 6 years of age. Although it is generally a self-limiting condition, Henoch-Schönlein Purpura can cause what is known as so where I've mentioned, for example, as part of the beginning, where there's abdominal pain. That abdominal pain can be linked to what is known as acute gastrointestinal manifestations, and that means there could be bleeding within part of the gastrointestinal system, and or renal kidney manifestations with various with various indices. Age of onset is suspect risk for renal manifestations in Henoch-Schönlein Purpura. Etiology of HSP is actually unknown to an extent, although a variety of antigens such as infections, vaccinations, drugs, foods, insect bites can actually trigger the onset of HSP. The disease is characterized again by deposits of what is known as immunoglobulin A, or IgA, which contained immunological complexes and complement components in a small blood vessel, in small blood vessel walls. It is generally agreed, or the consensus has been, at least where the literature is concerned, that the indices of HSP, Henoch-Schönlein Purpura, decreases with age. The proportion of children or young people presenting with renal involvement or kidney involvement and HSP has been reported in studies varies from 20% or 10%. So in a descending percentage sort of context. So So and then around this work, apart from providing the introduction and sort of background around the epidemiology, the aims and objectives of this work were as follows. The aims included to provide a practical understanding of HSP, Henoch-Schonlein Purpura, to provide an understanding of what further multidisciplinary care is required for patients with Henoch-Schonlein Purpura, and three, to highlight how laboratory practices could be enhanced to support the development of HSP care guidelines. I'm now going to delve into a little bit around the biomarkers around this. So there are no specific diagnostic biomarkers of HSP. However, if patient is presented with HSP, anemia usually is usually a result of gastrointestinal bleeding or associated with acute nephritis. So the gastrointestinal bleeding or can be linked or can be, sorry, I'm gonna rephrase this. Basically, where gastrointestinal bleeding can be so severe that it actually causes a detriment to the kidneys at very early onset. So there's acute inflammation, acute nephritis around the kidneys, and then thrombocytosis. Thrombocytosis can occur, but again, as mentioned, there is palpable purpura with thrombocytopenia with a low platelet count, but thrombocytosis or high platelet count is a feature that may also be related to disease severity. So renal involvement results again in haematuria with or without proteinuria, which may be in the nephrotic in the nephrotic or in the nephrotic range, where basically patients are diagnosed similar but not completely as those who might be diagnosed with what is known as IgA nephropathy. A rapidly progressing nephritis may result in renal insufficiency and requires histological assessment. There is actually, from a hematological standpoint, there is a particular clotting investigation that can be implemented for such individuals. So the clotting investigation, von Willebrand factor antigen, is synthesized by and is present in endothelial cells. High concentrations of von Willebrand factor has been detected in patients with Henoch-Schonlein Purpura, as with other vasculitic diseases, probably because of what is known as vascular endothelial damage. So an association with disease activity has been noted, and this may be a useful marker of disease severity. So von Willebrand factor has because of the gastrointestinal involvement and also gastrointestinal involvement, but also in relating to clotting, where there can be a variation between thrombocytosis and thrombocytopenia. In this context, an association and disease with disease activity varies, and it has been noted in the literature. This may be a useful marker of disease, may be a helpful marker of disease severity. However, soluble thrombomodulin is also important and is derived from damaged endothelium, which may reflect endothelial injury. Now, when patients are diagnosed with HSP, at that point, the clinicians would warrant or request particular clotting diseases, clotting investigations. Factor 8, there's a clotting factor 8 and von Willebrand's factor and potentially factor 5 Leiden are investigations that may be requested to look at the patient's sort of clotting ability, along with other particular investigations. Now, routine coagulation tests are normal, while factor 13 activity has been reported to be low, especially in patients with severe gastrointestinal disease. So I'm now going to talk a little bit about Henoch-Schonlein Purpura practice in context with chronic kidney disease and laboratory practice as well. So renal involvement rarely precedes the appearance of the purpura and usually occurs within the first 3 weeks of the illness. It ranges from isolated microscopic haematuria, proteinuria, or nephrotic syndrome, which is nephritic or nephrotic syndrome, where patients can find more than 3 grams per 24 hours of protein leaking and more than 40 milligrams more than 40 milligrams 40 milligrams squared in children or younger people. Now, to acute rapidly progressive glomerulonephritis. So what happens in this particular disease is there can be a shift, can be a shift where the disease is initially there's as mentioned, there's gastrointestinal involvement, but the disease can shift because the disease shifts because of generally from a physiological perspective. What happens is that the purpura, which relates to the bruising, can be extensive, so it can affect different parts of physiology or systemically, and then at least where the kidneys are concerned, because kidneys are generally more vulnerable organs, there can be scarring around the kidneys at early onset, which also can be provide a mixed sort of diagnosis that can also relate to glomerulonephritis. Glomerulonephritis meaning scarring around the glomeruli, the functional components of the nephrons. And it can be associated with either high blood pressure or renal failure, from the outset. Renal disease or renal damage around patients who are diagnosed with HSP tends to happen almost a little bit later. Depending on the diagnostic criteria, the frequency of the renal involvement varies from 20 to varies from anything from 20% to 100%. Overall, an estimated 2% of children or young people with HSP do experience kidney disease or renal failure. In one study, the frequency of chronic kidney disease in adults was estimated to be 1%, and the end-stage renal disease to be less than 1%. The frequency of renal failure was reported to be 10% to 20% in adults, and 1% in 1% in children or young people. Retrospective cohort studies reveal some degree of initial renal involvement in about 20 to 54% of HSP patients, ranging from isolated haematuria and or proteinuria without any abnormality in renal function and blood pressure or hypertension. So why I'm giving you, I'm providing this perspective around HSP. Basically, HSP in adults links has some linkage or can have some linkage to what is known as hemolytic uremic syndrome, where there is where generally in some contexts from a hematological point of view, both HSP hemolytic uremic syndrome and Henoch-Schonlein Purpura fall under the category where there is microangiopathy, so thinning of the blood vessels, and also there can be thrombocytopenia, but also can be thrombocytosis as well. So the difference around those two is that is how an individual falls into renal disease specifically. So with hemolytic uremic syndrome, and hemolytic uremic syndrome isn't discussed in this particular overview of this poster presentation, but suffice to say, hemolytic uremic syndrome patients can be diagnosed because of infected meat that they may consume, and with HSP, it is more to do with where patients are diagnosed based on the main premise around the gastrointestinal system, but also how blood vessels around the blood vessels and the physiology around the gastrointestinal tract and the kidneys are vulnerable to thinning, but also vulnerable to ischemia or clotting, and so this work also so yes, as mentioned, in this work where I mentioned that, so there can be issues related to renal function where hypertension or blood pressure is concerned. To acute nephropathy with renal involvement. So there can be acute inflammation to the renal tissues, and thus leading to renal impairment. In this poster presentation, there are a few tables as well, and I will highlight a few things around that. But suffice to say that table 1 in this work summarizes defining features, and then renal manifestations generally occur over a period of 28 days after the initial presentation of HSP. So you can those who are listening to this presentation or will check it out, checking it out through the Renal Patient Support Group, through the YouTube channel, for example, can get an idea of how quick pediatric nephrologists or nephrologists generally would have to pick up on patients who are diagnosed with HSP. So within 28 days, they have to act quickly, so the patients actually patients are aligned to care pathways. Generally occur over a period of 28 days after initial presentation of Henoch-Schonlein Purpura, and gross or microscopic haematuria, haematuria, proteinuria, or even nephritic syndrome may occur. And Table 2 in this poster presentation highlights the criteria for hospitalization for these particular patients. Now I'm going to talk a little bit about the multidisciplinary team laboratory practice aspect around this particular disease. So Streptococcus vaccines, viral infections, measles, varicella, rubella, hepatitis A, or B, tuberculosis, mycoplasma, Bartonella, Helicobacter pylori are stated as the trigger factors, at least in the literature, for HSP. This is so from this straight away we could this is a multidisciplinary disease, and affects the skin, the joints, the gastrointestinal system, the kidneys, and in addition, more rarely can affect the central nervous system, the heart, and in males who are diagnosed, and it is more male predominant, can affect the scrotum as well. Its pathogenesis and causal factors have not accurately been identified, at least in some regard. Viral and bacterial infections, drugs, vaccines, food allergy, and even insect bites have been considered in the etiology of HSP. It is thus important to appreciate that where supporting clinicians with laboratory diagnosis, HSP requires multidisciplinary team laboratory practice. So Table 3 in this poster presentation provides a summary of the importance of multidisciplinary team laboratory practice, and Table 4 in this poster presentation provides a summary around HSP clinical pathological findings. So reduced glomerular filtration rate is linked with a worse long-term renal prognosis. Early identification of impaired renal function is an important part of biomedical practice and disease progression. Haematuria is commonly presented in HSP nephritis and usually runs a benign course when isolated. Macroscopic haematuria for more than 7 days in one study where they talk about a particular cohort was rare and would require further investigation to explore the differential diagnosis. Table 5 in this poster presentation summarizes the critical microanatomy of HSP, so it is better to take into great consideration disease progression and prognosis. I am going to now talk a little bit about what's in these particular tables in these particular tables around in this poster. So table and this generally the table poster in the poster presentations fall under the category of biomedical and clinical anatomy practice. So Table 1, as mentioned, provide context around the defining features. So most common systemic vasculitis in children, there's vomiting, there can be abdominal pain and gastrointestinal bleeding, there can be joint pain, there can be haematuria, proteinuria, there can be nephrotic syndrome. And nephrotic syndrome gives the mixed picture as well. Systemic small vessel leukocytoclastic vasculitis, so where the leukocytes can cause a bit of a detriment to the endothelial to the endothelial, and then purpuric skin lesions on arms, legs, and actually on the behind of patients who are diagnosed as well. And then criteria for hospitalization in table 2. So there's basically where there's inability to maintain adequate hydration with oral intake, there's severe abdominal pain or significant gastrointestinal bleeding, there's changes in mental status as well. There can be severe joint involvement limiting ambulation and or self-care, and there is also renal insufficiency, elevated where there's elevated creatinine. There's also hypertension, and again nephrotic can be nephrotic. There can be nephrotic syndrome. Table 3 is the remit around the laboratory investigation, the types of laboratory investigation, and the typical finding. So full blood count, for example, the full blood count may indicate anemia and leukocytosis. There's an investigation called the erythrocyte sedimentation rate, which is normally normal or slightly raised. And again, like most investigations, erythrocyte sedimentation rate can be pretty inappropriate. So it doesn't on its own is not indicative of individuals having HSP. Coagulation in some contexts can be normal, but there can be problems with patients' platelet counts, and so there can be thrombocytopenia, there can be thrombocytosis, there can be low or high platelet count, but on its own, again, coagulation can also look relatively normal. The biochemistry renal function may be abnormal with a raised creatinine, a low albumin, so there's low albumin and might be related to directly related to gastrointestinal disease. There's also tests and investigations that align to the microbiological investigations, but again, the microbiological investigation, much like the hematological and the biochemistry, the tests do not provide a definite on their own. And then there's also there's urine dipstick and protein creatinine ratio. So there can be hematuria where patients void blood in their urine, and with that there can be proteinuria where patients are leaking protein through their urine through voiding, and then basically that can lead to problems with the renal function. And then there's investigation around the septic screen, if diagnosis is unclear, purpura and purpura, if diagnosis is unclear and purpura present. So septic screen is quite useful, but again should be is an investigation that is requested along with other investigations. Now, just an overview on the clinical pathological findings. So there's significant clinical pathological differences with IgA nephropathy. So this As I mentioned earlier, the HSP can, because of its devastation and how it occurs, can be mixed with IgA nephropathy and nephrotic syndrome and focal segmental glomerulosclerosis in some contexts, or FSGS, generally, the nephrologists within that 28 days that they investigate, they have to rule out all of these very quickly, or else the patient will actually die. Renal symptoms in 30 to 70%. Renal symptoms or kidney symptoms in 30 to 70%. Some adults develop rapidly progressive develop rapidly progressive glomerulonephritis. 70% progressive glomerulonephritis. 70% are ages, again, in the age range between 2 to 11 years old, and is rare in adults or infants 1 year old at 1 year of age or less. Higher rate of renal involvement in children ages 10 to 18, and it's associated with atrophy. So there's general inflammation, and respiratory infection may follow as well. Related to IgA nephropathy can be due to elevated serum of IgA circulating immune complexes with IgA, and creates a similar kidney lesions. So there can be scarring, which cause lesions around the kidney and around the gastrointestinal tract. High serum galactose deficiency immunoglobulin A1 level is also demonstrated, or has been known to be the case in some patients who are diagnosed with HSP. There's high blood pressure or hypertension, serum creatinine, proteinuria, cellular crescents, glomerular necrotizing lesions, and chronic renal lesions are associated with the development of renal failure or kidney failure, and there are variable recurrence rates in 12 to 69% after renal transplant as well. However, it's not clinically important. So once someone is transplanted, for example, the symptoms of the symptomology to some extent reduces, although the patient will have skin lesions or purpura as mentioned, generally, and because of the with some patients, or most patients, certain drugs are taken in the long term, and that will also cause bone softness, which again doesn't unfortunately does not actually help the individual over time, because of the arthritic kind of symptomology that they are diagnosed with when diagnosed with HSP. So the summary around this is thus HSP is still considered somewhat rare. Systemic non-thrombocytopenic vasculitis affecting mostly children between the ages of 2 and 10 years old. In this age group, the outcome is almost always excellent and requires only supportive care. In other age groups, atypical presentations are also common. Renal consultations and to a lesser extent gastrointestinal, pulmonary and neurological complications can be severe, can be severe and difficult to diagnose with what is known as a biopsy of the affected system. Urinalysis is the only investigation required in a classic presentation of HSP. Further investigations may be required if the diagnosis is unclear. Abdominal symptoms are severe, or where there is evidence of significant renal involvement, and hypertension, macroscopic haematuria or proteinuria in that regard. Most cases are self-limiting and require only symptomatic management. Close follow-up is critical to identify significant renal involvement with request intervention. Such renal involvement can be asymptomatic as well. So that is an overview of this poster presentation. Henoch-Schonlein Purpura, biomedical and clinical anatomy practice on this multidisciplinary disease. This was again accepted for poster presentation at the International Pediatric Nephrology Association conference for this year in 2022. And overall, it can be highlighted. I could say that HSP is truly a biomedical, a multidisciplinary disease. The full paper is available through the Renal Patient Support Group, the RPSG, and it's titled Henoch-Schonlein Purpura, What Can We Learn from Biomedical and Clinical Anatomy Practice on this Multidisciplinary Disease. It was published in 2018 in the Austin Journal of Anatomy. This work was collaborative between the RPSG, the Renal Patient Support Group, and two academic institutions as well. So I hope this overview provides a basis of Henoch-Schonlein Purpura. One final thing, I do want to dedicate this to one of the co-founders of the RPSG, and that's John Gardner, who was diagnosed with HSP when he was very young. He was at the age of 13 or just around 13 years of age, so this work is in dedication to the co-founder of the RPSG, the Renal Patient Support Group. Thank you for listening, and I hope this has been informative. Once again, feel free to use the timestamps in the YouTube to take any notes if and where necessary. Thank you very much.